immense pleasure in introducing our speaker for today's session, Dr. Bhageerath sir. He is currently working as a cardiologist at Bhageerath Cardiac Care Center and Relief Hospital, Warangal. Also, the co-founder of Sujeevan Health and Wellness Center. Sir has completed his MBBS from Guntur Medical College in the year 2004 to 2010. He pursued his MD in General Medicine from Andhra Medical College in the year 2015. DM Cardiology from Usmania Medical College in the year 2015 to 18. He secured first rank in the DM exams. He worked as interventional cardiologist at Mallareddy Narayana Hospital in the year 2018 to 19. Sir has done more than 700 angioplasties, including 200 primaries and more than 2,500 angiograms as primary operator with excellent success rate. Apart from all these, Sir has conducted research particularly on acute coronary syndrome, thrombolysis, atrial fibrillation, heart failure. We are certain that many more such endeavors will await Sir. Well, request you to take on the session. Thank you.
Thank you so much. At the outset, I would like to thank Pharm Society for giving me this wonderful opportunity. And I also congratulate Karthik and Alvin for doing such a great job, mobilizing so many talents all over the country and organizing such a wonderful webinar. Coming to today's my topic, integrated medicine to tackle cardiovascular diseases. So we started Sujeevan for tackling these risk factors, especially not just treating the disease. And my brother already introduced about the company in his previous talk. And coming to the vision, we provide whole person-centered care and services. We treat illness, we provide health promotion, decrease morbidity, and increase the lifespan of a person. This is our vision. And coming to the mission, Sujeevan is committed to deliver highest quality of health services, including prevention, promotion, and medical care for all by using a holistic approach. We treat the person as a whole. We treat mind, body, spirit, along with disease. And coming to the timeline of our company was started in 16th February 2020. And we have a team of doctors, psychologists, physiotherapists, dietitians, yoga therapists, health coaches, physical trainers, pharmacists, and lab technicians. We all together try to solve the problems, treat the root causes of the diseases. And during this course, once we started our company, we got the major challenge, that is COVID pandemic. And but we didn't step behind. We treated every COVID patient possible to us, and we treated almost like 500 to 1,000 COVID care program, including in the hospital and home care management. And now we are adding technology to our services. We are in the process of developing an app, which is going to be released by May 2021. Today's topic, that is cardiovascular disease. Cardiovascular disease is the major cause of death all over the world. Almost 17.8 million people died due to cardiovascular disease in a year, followed by cancer and respiratory diseases. And there are many risk factors for this cardiovascular disease. And all these risk factors land up in a single pathophysiology, that is atherosclerosis. Atherosclerosis is nothing but building up of fat, cholesterol plaque in an arterial wall, further leading to blockage of arteries. Here is a short video showing how atherosclerosis can damage the various organs by blocking the artery. So arteries are mainly meant for supplying blood to various organs. Here the formation of atherosclerotic plaque, building up of fat and this factor is dyslipidemia, cholesterol, high blood pressure, and smoking. All these cause damage to the arterial wall and of arterial plaque. Whenever there is breakage in the fibrous layer on the plaque, they can cause blockage of the artery, leading to infected organ, that is heart attack and stroke. So now coming to the stenting, stenting is nothing but dilating the blocked artery by the help of a balloon and followed by stenting, which further helps in allowing the blood flow to supply the organ. Here is one case report where I show a 55-year-old male who presented to our hospital with blocked artery in the distal part of the RCA. He is an RTC driver and a smoker, 55-year-old male. So here you can see I passed a wire into the blocked artery and I just passed the balloon, and you can see some flow is coming to the distal part of the RCA. And once the distal part is dilated with the balloon, we can see some good amount of blood again coming to the distal part of the RCA. Now I passed the stent and dilated the vessel, and stenting was done. Now we can see good amount of blood flow to the distal part of the artery after stenting. I have just post dilated it, and the patient is now in 1 year follow up and is doing fine. But the question is, what made the patient land up in this complication, that is heart attack? So risk factors. Coming to the risk factors, major risk factors are obesity, that is BMI more than 30 especially, and hypertension, blood pressure more than 140/90, diabetes, fasting blood glucose more than 126, metabolic syndrome, which together with having a high hip waist ratio and high total cholesterol and physical inactivity. Low socioeconomic status is a risk factor, and a family history of premature cardiovascular disease. These are the major risk factors which make the patient land up in heart attack or stroke. Other risk factors such as low HDL cholesterol, elevated triglycerides, especially seen in alcoholics, left ventricular hypertrophy, seen in patients who are having higher blood pressure, that is hypertension or aortic stenosis, raised serum creatinine, those seen in patients with renal failure, albuminuria, common in diabetes, C-reactive protein, which is an inflammatory marker, hyperuricemia, increased uric acid levels, and fibrinogen. All these risk factors make the patient land up in atherosclerosis and further can cause blockage of arteries. To sum up, total cardiovascular disease risk is defined as the probability of an individual experiencing a cardiovascular disease event, that is MI or stroke, over a given period of time, that is 10 years. How to assess clinically for a patient of cardiovascular disease is by developing a tool called with the help of 4 aims. One is to search for all cardiovascular risk factors and clinical conditions of the patient, then to determine the presence of target organ damage, to identify those at high risk and need of urgent intervention, and to identify those who need special investigation or referral. So first is identifying risk factors, then identifying target organ damage, then assessing those who need urgent intervention should be referred, and special investigations and referral. This is one risk score chart showing 10-year risk of fatal cardiovascular disease in population of high cardiovascular disease risk score. This is given by European Society of Cardiology. It includes risk factors like hypertension, total cholesterol levels, age, and smoker, and sex. The other scoring algorithms are like Framingham risk score and ASCVD risk score. The risk score can help us in assessing the patient landing up in future heart attacks or strokes in a given period of time. Coming to the risk factors in detail, one is obesity. Obesity is nothing but increased body fat, which indirectly contributes to heart disease through promotion of sleep apnea, thromboembolic disorders, and onset of worsening metabolic diseases that are major cardiovascular disease risk factors, including dyslipidemia, type 2 diabetes, high blood pressure, and metabolic syndrome. So those patients who are obese are also having metabolic syndrome. And the most important risk factor, diabetes. These patients are more prone for cardiovascular diseases. Hence, it is given a special term called cardiovascular disease risk equivalent. So, prevalence of diabetes mellitus continues to rise, especially in India. This is associated with cardiovascular disease through both traditional cardiovascular risk factors and direct effect of diabetes mellitus. So proper control and treatment of diabetes mellitus along with aggressive treatment of associated cardiovascular risk factors like smoking is central to curbing the growing prevalence and progression of diabetes mellitus and cardiovascular disease. And the other important risk factor is psychosocial factor, which is not commonly dealt, but evidence from observational studies has indicated that depression, anxiety, lack of social support, social isolation, and stressful conditions at work independently are the predictors of coronary heart diseases. The other risk factor, most important risk factor, is smoking. Smoking is one of the important risk factor for formation of plaque in the blood vessel. Coronary artery disease occurs when arteries carry blood to the heart muscle are narrowed by plaque or blocked by clots. So most of the several systematic reviews have shown that even if we advise once, during routine consultation, 2% of smokers quit for at least 1 year. So counseling during clinical visits is the most important, which can help the patients in quitting smoking and decreasing the patient landing up in complications. Next important risk factor is hypertension. Hypertension has become a silent killer of the world by causing increased heart attacks, increasing brain strokes, increasing kidney failure, and also it complicates pregnancy by causing eclampsia and preeclampsia. So the factors that reduce the hypertension are weight loss definitely helps in decreasing the blood pressure, physical activity decreases blood pressure, decreasing the alcohol intake, and increasing fruits and vegetables which have more increased potassium and decreasing sodium can cause reducing hypertension. Sedentary lifestyle is the most important risk factor that has increased the coronary artery disease in recent days, especially those people who are in multinational companies and software jobs. They sit hours together. They don't have any physical activity, and even in most of the business people also stick to their sedentary lifestyle. But if they become physically active, they can decrease their coronary artery disease risk. Physical activity improves endothelial function by enhancing vasodilation, increasing vasomotor function in the blood vessels. So whenever the blood vessel gets narrowed, there will be increased chance of patient landing up in heart attacks. And this physical activity helps the patients in dilating the blood vessels. That will further increase the blood supply to the target organs. In addition, physical activity also contributes to weight loss. As we already dealt, obesity is one of the major risk factors. Diabetes is also a risk factor that can be decreased by physical activity. Hypertension can be decreased by physical activity. Dyslipidemias, and it also improves insulin sensitivity. So physical inactivity and low physical fitness are independent predictors of mortality in patients with type 2 diabetes mellitus. Next most important is diet. More cholesterol, more saturated fatty acids, and more trans fatty acids. More trans fatty acids in the diet are the major risk factors for coronary artery disease. So we should try to decrease the amount of saturated fatty acids and trans fatty acids in our diet to less than 10% and increase polyunsaturated fatty acids, which are seen in olive oil and soybean oil. So that trans fatty acids are hydrogenated saturated fatty acids, which are seen in that oil which is boiled for longer time, especially seen in outside food. Fruits and vegetables will definitely help in decreasing the cardiovascular diseases because of various components that are present in fruits, like micronutrients, antioxidants, phytochemicals, flavonoids, fiber, and potassium. Each increase of one serving per day that is about 400 to 500 grams per day, will decrease 4% of coronary artery disease. So, how to reduce the cardiovascular diseases? By simple life, simple 7, that is stopping smoking, eating better, losing weight, controlling cholesterol, getting physically active, reducing the blood sugar, and managing the blood pressure. For this, behavioral modification is the most important technique, and healthy lifestyle will definitely help us in decreasing the cardiovascular disease risk factors. It is time to change our emphasis. That is, we should not focus still on those patients who already landed up in the disease, but to prevent the risk factors and treat healthy persons too. That is transferring from sick care to health care with great focus on prevention and foundational causes of cardiovascular disease. Changing behavior is not that easier, as said, but however, it is not impossible. Tailoring messages, lifestyle counseling to patients' readiness to change increases the likelihood of success and favorable outcomes. Most of the studies now suggest that behavioral change and multifactorial risk factor modification, especially smoking cessation and more intensive measures to control weight, hyperlipidemia diet, and compliance to drugs, these can slow the disease or even reverse the disease, the otherwise inexorable progression of atherosclerotic coronary artery disease occurs. Coming to the 10 strategic steps to facilitate lifestyle behavior changes, to start with, first step, we should develop a therapeutic alliance. We should know the socioeconomic status, attitude, and cultural factors of the patient. Then next step is to increase the motivation and making the patient self-efficacious to lifestyle change. Then we should help individuals better understand the complications that occur due to lifestyle behaviors. Followed by the next step, we should assist the individuals to identify their specific barriers like finances and psychosocial factors. Then we should strategize the patients to identify realistic options. We should not say like for a patient like who is having sedentary lifestyle with BMI around 40 to come to 25, that is normal. We should start like with few steps, at least 10 minutes walk a day. Then we should try to increase the amount of physical activity so that the patient can cope up and strategize that is realistic to him. Next step is to delineate deleterious lifestyle habits. So if the patient is like having smoking, that should be changed. And once he delineates the deleterious habits, we should use varied counseling strategies. We should keep follow-up messages, and we should reinforce patient readiness for lifestyle change. Everything should be given in a written form, written lifestyle modification plan. Then we should involve multidisciplinary staff, not just staff, but also spouse or partner, family members, and friends whenever possible. And the final step is to monitor the progress by messaging, emails, completion of dietary or smoking cessation logs, etc. And this is a beautiful 5A strategy to facilitate behavior change. First A is like ask physical activity vital sign. Then we should advise encourage physical activity. We should assess the readiness to increase physical activity. We should assist them in treatment plan, and we should arrange a follow-up. So these are all about treating and facilitating behavioral change for those patients who are having risk factors. Now coming to secondary prevention, for those patients who already have heart disease, what is to be done? That is cardiac rehabilitation. For a patient who had a heart surgery, heart attack, who had an ICD, implantable cardiac defibrillator inside the heart, and for those patients who are in heart failure, and for those patients who has underwent coronary angioplasty and stenting. These are done in 4 phases. Phase 1 include counseling during the hospitalization, that starts on the day of procedure itself, by making the patient sit after the procedure, after 6 hours of the procedure, and that is early mobilization. In phase 2, that happens within 14 days, where we target making the patient go up to the bathroom or climb up 2 stairs, and we should monitor this phase 2 program with the ECG. We should assess, we should see that his heart rate is not more than 20 from the baseline, and we should also look for blood pressure should not fall more than 20 during the procedure, or increase more than 20. Coming to the phase 3, this is supervised exercise come education sessions that is done 6 to 12 weeks after the heart attack or MI, where we check for exercise tolerance with treadmill, and we see that target heart rate is around 70 to 80 for low risk patient, and it is around 60 to 70 for moderate risk, and less than 60 of target heart rate for severely risk patients. These patients in phase 3 are also monitored with the ECG support. Coming to phase 4, that is a long-term lifestyle change that will make the patient decrease the risk factors and make the patient not to land up in second attack. Here, the ECG monitoring is not necessary. We just follow up the patient, and we should make them continue the lifestyle changes. We increases the home visits and rehabilitation centers periodically. Coming to the benefits of this cardiac rehabilitation for the patients who already landed up in stroke, there will be freedom from angina. For those patients who are in cardiac rehabilitation, have less number of chest pain complaint compared to those patients who are not under cardiac rehabilitation. And these patients can do more things compared to those patients who are not in cardiac rehab, and they can join the work, they can join the job sooner, they can enjoy all activities. They can work out smart, they can get in shape. So we involve family and friends, they can manage stress better, and they use lesser medications compared to those patients who are not under rehabilitation. Then complications of heart attack like heart failure is low in those patients who are in rehabilitation, and they can save money by decreasing the number of post heart attack admissions, hospital admissions. This will improve the ejection fraction, and this can also reverse heart disease in few. So this is our team who work in BCC. They also work for cardiac rehabilitation, and these are few testimonials. Case 1, this is a 50-year-old male who presented with coronary artery disease, unstable angina, had a BMI of 36. This patient had obstructive sleep apnea. He underwent stenting in LAD and had 50% stenosis in RCA. He is on regular medication and was advised weight loss 1 year back and dietary modification. Now his check angio after 1 year revealed regression of plaque, and now there are no signs of obstructive sleep apnea. His BMI is around 27 right now. This is another patient, 35-year-old male, had heart attack in younger age. He's a smoker. His ejection fraction was less than 35 before the procedure, and he underwent stenting to a left anterior descending artery, and he was also advised behavioral modification. He's doing fine after 1 year, and after changing the diet and physical activity after cardiac rehabilitation, now his EF is around 55, and he's doing fine. No hospital admissions, no angina, and no heart failure symptoms. So I thank you for giving this opportunity. I would be happy if this is like more interactive. If any questions, I am happy to answer. How this cardiac rehabilitation helps in decreasing the anginal episodes.
Good evening, sir. Myself, Satyashree. So, I have a small doubt.
Yeah, yeah.
Recently, I have come across a case where the patient is hypothyroidic since 10 years, and the patient has rheumatic heart failure. The patient is using levothyroxine 100 mcg, but how far is it correct, sir? Like, we already know that levothyroxine further worsens CAD or any other heart problem. So, the patient, what should be done? The patient should be continued on the medication, or is there any need to reduce the dose or something like that?
No, no, no. Whenever the patient is having hypothyroidism is one of the major cause for heart failure. They should be treated on adequate dose. It should be monitored with TSH levels, and once the TSH levels are within the range, then that amount of dose should be continued. Decreasing the dose or increasing the dose will depend on TSH levels and monitoring the patient. That should be definitely continued. Once you get TSH levels done and if the dose is sufficient, then you can continue with the same dose.
Okay, sir. Thank you, sir.
Hello, sir.
Yeah.
Yeah, good evening, sir.
Yeah. Good evening.
Sir, I came across sir, I had a doubt regarding a case, sir. I came across a patient. So he was 23-year-old male patient, sir, who had prolonged tachycardia, sir, and he had been diagnosed with anxiety. Due to that, he was started on initially on metoprolol, but then later was changed to ivabradine, sir. Rest all the ECG and the 2D echo that showed the reports were fine. So how can we analyze the patients next for those situations, sir?
Yeah.
They ruled out Brugada syndrome and other syndromes too in that boy, sir.
Okay. So sinus tachycardia is one of the major thing that we see in day-to-day practice, especially in young people. ECG is a major important tool where we can assess whether it is a sinus tachy or sinus or any other supraventricular tachycardias. Once we rule out all other supraventricular tachycardias and diagnose it as sinus tachycardia, we should check his blood levels, thyroid hormones, hemoglobin levels, and other causes that can cause sinus tachy. And if all other physiological and pathological causes are ruled out, then we can make the patient diagnosed as anxiety disorder causing severe tachy. We have treated such patients with just lifestyle modification, especially yoga, increasing physical activity, and increasing physical activity will definitely help such sort of patients, especially in decreasing the heart rate. And those patients are doing fine who have joined these programs in Sujivan.
Thank you so much, sir. I understood.
Most of the youth and young adults are suffering from this anxiety disorder. They present with, especially due to during exam season, and they have slight elevation in blood pressure and higher heart rates. Um, Behavioral modification will definitely help in decreasing the heart rate. Then only once if the behavioral lifestyle modification is not working for them, then we go for beta blockers or IF funny current channel inhibitors like ivabrat.
Understood, sir. Thank you so much, sir.
I will be happy to answer any more questions.
Hi, sir. Good evening. This is Shazia.
Yeah, Shazia. Tell me.
Hi, sir. Thank you so much for today's session, sir. Because I am doing a project on the same topic that you took today. Sir, I had a few questions like while categorizing the patients on the basis of risk, for high risk
I
patients,
didn't get you. Just be louder. No, I'm. Your question is no. I am unable to hear.
yeah, sir, I'll repeat it. Sir, we are doing the project on the same topic that you took today,
Okay.
and that will really help us for a lot to know. And sir, while categorizing the patients based on their risk, we are using ACVD risk score, sir.
Okay. Yeah, that is one of the common risk score that we use in our clinic too.
Yes, sir. So for that, so we need their LDL profile, both the lipid profile and the HbA1c, no, sir.
Yes.
And that is not usually performed in our hospital. And
Okay.
also for prescribing the statin, sir, whether you go for moderate intensity or high intensity, we
Okay.
also need the lipid profile. So, sir, when asked to the cardiologist, so we got an answer like most of the patients they're obese. So we just start with the high intensity statin. So to what extent is this right, sir? Can you
No,
give
no,
some
no.
insight?
If you are like doing ACVD risk score, if the ACVD risk score is more than 7.5, and or the patient if he is already having any peripheral artery or coronary artery disease, then only he should be kept on high intensity statin, that is atorvastatin 40 or 80, rosuvastatin 20 or 40. Once the if the ACVD score is less than 7.5, then they should be kept on moderate intensity statins only.
So, sir, what can we family students do about it, or uh, any other
So
suggestions?
if you don't have no, the thing is definitely lipid profile should be done, and that will only help us in assessing the risk score. If without any lipid profile, if you want to keep the statin, he should be already a patient of some atherosclerotic damage to the target organ like brain stroke or heart attack or some kidney disease with renal artery stenosis. If that patient is diagnosed with these complications, then even without lipid profile, you can keep him on higher intensity statins. But even then, we should try to go for lipid profile. That is what I suggest,
So, what
because
about
that is
the
the
cost effectiveness?
basic investigation is available anywhere in the world.
Yes. So one answer also that we got was about the cost effectiveness because patients are already having angio and also based on the percentage of stenosis, they were prescribing the statins and also they were trying to reduce as number of tests that they can reduce to just minimize their cost.
Yeah, yeah. Some patients do complain new onset diabetes because of statins, and some patients also complain muscle spasms, muscle cramps, and they few of them had higher levels of creatinine phosphokinase where muscle got damaged. So prescribing high intensity statins without any basic lipid profile or HSCRP is like not indicated for all, unless they are in complicated target organ damage due to atherosclerosis.
Thank you, sir. Sir,
Also, always even do monitor sugar levels once they are on high intensity statins.
yes, sir. So this HbA1c, not most of the patients are being advised to get their HbA1c done. Not even in the OP, sir.
Okay.
So what about those cases?
Even I am in because diabetes is the major cause of coronary artery disease. It is given a term called cardiovascular disease risk equivalent. So definitely diabetic screening should be increased, and I support diabetic screening should be increased. Nowadays, HbA1c is being done, which is not that cost effective compared to random blood sugar. But even then, if the patient are like affordable, they can go for both, or at least random blood sugar screening should be done for all the patients who come to the clinic.
Okay. So, can you
That will
just
definitely help in decreasing the burden of atherosclerosis and complications. Diabetic screening and hypertension screening should be a rule for every clinic.
yes, sir. Thank you, sir.
In the long
So,
term, that will definitely decrease the cost burden on the patient itself.
yes, sir. Ultimately, yes. So,
one more question. So as you mentioned on the secondary prevention about cardiac rehabilitation, you see how many the episodes or the frequency of angina has it got reduced or not? For that, we thought of using that Seattle angina questionnaire, sir, to
We thought of
understand
using.
Seattle angina questionnaire, sir,
Okay, yeah.
for
Angina
just
patient.
assessing
Yeah.
assessing yes, sir, for assessing how much is the frequency reduced or just an outcome kind of thing,
Okay,
whether managing your risk factors reduced it or not. So, sir,
okay.
when asked about it, we got an answer it is whole and soul about the diagnosis, not the outcome. So, can you just guide on that too, sir? Can we use it as an outcome thing or?
You are asking like the patients who had angina post procedure, will that help in prognosis? That is what you are asking?
So, any patient with established atherosclerotic cardiovascular disease, sir?
Okay. So the amount of anginal episodes, whether will it help? That is what you are asking, right?
Yes, sir. Yes, sir. Can we use it? Can we use it as an outcome measure, sir? Like whether the therapy has worked or not, or any intervention that they've gone through whether
Yes,
it
yes,
is
yes, yes, yes. That can be definitely. Yeah, symptom itself is a factor that we can assess from outside that the patient is suffering inside. So whenever there are more anginal episodes, that will decrease his lifestyle, and that will definitely make the patient suffer. So that will help to assess the outcome. So we always try to, once the angiogram is done, and if we come to know that stenosis is less than 70%, and even then the patient is having more anginal episodes, we can cut short, we can decrease our percentage stenosis for revascularization to 60 or 50 also. But if the stenosis is like 20-30%, but still the patient is having anginal episodes, then there is an entity called microvascular angina, where we can't do any procedure to him, but he should be treated for angina. For them, the prognosis is comparatively bad when compared to those patients who are not having any angina. They should be treated with many anti-anginal drugs are available, like sorbiturates, and even metabolic drugs that act on fatty acid metabolism, like trimetazidine, flavidan MR, even ranolazine will help in decreasing the angina episodes. Those patients who are complaining of angina, they should be definitely given a concern, and check angio or repeat angio should be done if necessary.
okay, sir. Thank you so much, sir.
Good evening, sir.
Yeah.
This
Hi,
is
Sid.
Sita.
Yeah.
Sir, I have a doubt. If a person already attacked by brain stroke, what is the possibility of getting heart stroke? Can you clarify regarding this one?
So there is a sequence called, once the coronary arteries are involved, the chances of brain cerebral arteries involvement will be high, and vice versa too. Once there is cerebral artery involvement or carotid artery involvement, coronary artery involvement, there will be like high chance, and there can be also chance of peripheral artery disease. But most of the patients who had a brain stroke will be kept on the common treatment for atherosclerosis, that is statins and antiplatelets. That management will definitely help this decreasing the plaque burden in coronary arteries too. So the treatment that is done for brain stroke or cerebral artery atherosclerosis will decrease the coronary artery atherosclerosis too. Definitely there will be high chance if he is not treated with any statins or antiplatelets.
Okay, sir. Thank you.
Good evening, sir. Firstly, thank you so much for spending your valuable time in educating us on how to intervene to tackle this cardiovascular diseases. My question is, they say that usually when we do ECG, exactly we can't identify how many blocks or plaques are there in the arteries. And only when we go for angioplasty, we'll exactly know how many blocks are there. Is that true, sir? And one more thing is, what are the ways we can exactly identify or diagnose the various atherosclerotic plaques in the arteries?
Yeah, that's a good question. Like most of the patients come to us, especially with many risk factors. But once we do ECG and 2D echo, even 2D echo seems to be normal. Once we say to the patient that your ECG and 2D echo are normal, they feel that there is no block that is present inside the artery. But that's not true. So what we do is, if the patient is fit enough to do an uh, exercise, we make the patient go into treadmill test. We do TMT, exercise tolerance, and we check for the exercise tolerance and see whether there are any ECG changes that happen due to the stress that was kept on the heart with the help of exercise. Then if there is any ECG changes that happen during stress, then we make the patient go for angiogram. This is one beautiful non-invasive test where we can identify there will be the certain amount of blockage in the arteries without any intervention. And the other test is like stress echo, dobutamine stress echo. That is done in those patients who is not fit for exercise, and there will be regional wall motion abnormality once we give pharmacological stress, that is dobutamine, where there will be increased heart rate, and that causes stress on the heart, and that will help us in identifying those patients who have blocks even without angiogram. And the other stress is stress thallium test. This is a nuclear where we give a nuclear dye and we see the amount of perfusion and metabolism mismatch, and we identify those patients who are having blockages in the arteries. Once we find out there is some blockage, then only we go for intervention like angiogram, and finally find out how many blockages are there in the arteries. So in the resting phase, if we see that ECG is normal, 2D echo is normal, that is not going to help us completely to say that there are no blockages in the coronaries. Definitely we should go for further investigations. So those patients, by assessing the risk factors and calculating the risk scores, we can identify those patients who should undergo further investigations. Without any risk factors, we usually doesn't undergo any further investigation.
Thank you so much, sir. It was so clear. Thank you, sir.
So, hello, doctor. This is Karthik.
Hi, Karthik.
Yeah, hi. So, while going through your profile, I came to know you secured first rank in your DM exams, and you did your medicine and MD and DM from prestigious colleges. So, can you give any tips for budding students or certain qualities in you which helped you excel in your medicine?
Yeah, it's what I feel is like attitude towards attitude will definitely help us in successing getting success, and we should keep some higher targets so that it will be motivating us all the time to achieve our goals, and that goals and targets should be like uh, should not be like that easy, that will be achievable, and if that goals and targets are going to be helpful for the public, then there will be lots of good factors that will help you in achieving your targets. That is what I feel.
Yeah, such a nice answer. And one other question is like, on an average, how many hours do you use to read in your medicine DM and MD and DM days?
Yeah, it's not that like ours, but yeah, we used to read a lot because books are the only source of gaining knowledge. Nowadays, of course, we have so many tools to gain knowledge. We usually spend uh, we used to spend most of our times in the libraries only during our graduation and post graduation days. and um, it's not like in the leisures we used to do all other activities. It's not like we spend all the time in reading, but we used to like whenever entertainment activities are done, and all the remaining time was spent in studies only.
So the reason I asked is like lot of students, even though they get lot of time, they think they don't have time, and hardly I think they read
Yeah.
maybe 1 or 2 hours. But I have seen lot of my friends in medicine, even my own siblings.
Yeah.
Actually, that is insane. The number of hours they spend in reading and learning those concepts with every day, lot of new information coming, how they keep updated, etc. So it is a huge, huge effort.
And today's generation is always like, I feel they are lucky. Even now we are like lucky that we are getting updated with the help of all this technology, and I am able to pass some information to you guys, and simultaneously I am all learning too. Even though there is like pandemic, technology is also helping us to gain the knowledge. We should be thankful to the technology too.
Yeah. Yes. So any other questions if students have, you can ask, or any feedback you want to share, you can share your feedback.
Good evening, sir.
Yeah, hi, good evening.
The session was really great. I got to know about the cardiac rehabilitation techniques, like phases of it and the benefits out of it, and also the risk factors. And you explained everything in detail, like how obesity can affect, uh, and how it leads to atherosclerosis, and from atherosclerosis to cardiovascular diseases, that progression and all. And thank you for clearing all the doubts very patiently, and taking your time out of your busy schedule. So thank you so much, sir.
Thank you, Pharmacon Society, and thank you, Karthik. Thank you, Satya, for such a great introduction. Thank you.
Yeah, hi, this is Bharat here. Hello.
Yeah, hi, Dr. Bharat. We can hear you.
Yes, there's a question in the chat box, so I was just wondering, like, if you can see, Bhageerath, there's a question called says for complete heart block, which is better, angioplasty or stent? You're on mute. Bhageerath, you're on mute.
It's not like complete heart block angioplasty, or what is the question? I didn't get the question.
It's in the chat box. For complete heart block, which is better, angioplasty or stent?
See, angioplasty is nothing but dilating the vessel with the help of balloon. Whereas once we dilate the blood vessel, that is followed by stenting process, so that there will be no recoil of the vessel that was dilated. Angioplasty is defined by dilatation of the vessel, and stenting is the second step of angioplasty. But here the question is like complete heart block. Complete heart block is an electrical problem that is treated by pacemaker. Blockage in the arteries is different, and that is treated with the help of stenting.
There is another question on in the chat box. If you can check, probably it's posted in the YouTube.
For angiography, patient who has high serum creatinine, we prefer VC pack. Can you please explain the mechanism? Normally we use OmniPack, which has got ion osmoles around 300 to 340. VC pack is having lower osmoles, around 270. whenever the kidney function is low, the dye which has got lower osmoles can be excreted easier compared to with the higher osmolar contrast. So that is the reason why we use VCPAC for treating those patients, doing angiography and all. It's a lower osmol, that is osmotic contrast that is present in the VCPAC that is used.
So, doctor, I have a question. So, let's say if patient is posted for an elective surgery and he's on antiplatelets.
Okay.
So, how early should those drugs be stopped, and when should they be restarted? So, actually, I have seen a lot
So
of times.
yeah, most of the patients, especially those patients who underwent previous angioplasty or stenting, will be kept on antiplatelets, and after a course of time, they will be landing up in some other surgery. So at least we should take 3 to 5 days to stop antiplatelets before surgery to decrease the amount of bleeding burden with the surgery, with especially for ecosprin and clopidogrel. And meanwhile, the patient, if they are at high risk of stent thrombosis or high risk of blockage, they should be kept on anticoagulants like heparin or low molecular weight heparin, and that should be stopped. If the patient is kept on like heparin, it should be stopped 6 hours before the surgery, and if he is kept on low molecular weight heparin, it should be stopped 12 hours before the surgery. And antiplatelets should be started 12 hours, 24 to 48 hours after the surgery, whereas heparin can be started 6 hours to 12 hours after the surgery. Those patients who had long history of taking antiplatelets, and if we feel like chances of landing up in second stroke is low, then just stopping the antiplatelets is enough without any anticoagulant backup. Hello, sir. Can we use injection nitroglycerin for anterolateral MI whose BP was 100/60? If yes, why, sir? Thank you so much. So those patients, especially who has extensive anterolateral MI, those patients are high chances of landing up in severe heart failure and pulmonary edema. That sort of heart failure can be decreased. The burden can be decreased only with the help of injectables like NTG. Here we try to maintain at least systolic blood pressure of 100. If more than 100, definitely NTG will help, especially in those patients who landed up in pulmonary edema. NTG is nothing but a vasodilator, coronary arterial dilator that will vasodilation will decrease peripheral pooling of blood, and coronary vasodilatation also will help in increasing the supply of coronaries and improve the heart's function.
Actually, we will not take any more questions, so just have 2 minutes left. So anybody wants to share your feedback on what you felt and what you learned, you can do, and we can end the session.
Good evening, sir.
Yeah.
Sir, thank you for the session, sir. It was very informative. I learned a lot about the risks and strategies to improve the lifestyle modifications, and also how to sorry, sir, for the poor connection. Hello.
Yeah.
Yeah, I
Yeah,
heard
thank you.
only half of it. Yeah.
So, sorry, sir.
That's fine. Thank you for your good words to me.
So, Dr. Bhageerath, on screen, we have like shared a certificate. We donated it on your name for
Yeah, thank
initiative
you.
from
I was just reading. I was just reading that you have gifted 5 trees. Thank you so much for that, and that's a great initiative to revitalize Kaveri River.
So, yeah, this is just a small gratitude and token of appreciation from us. So, thank you for taking your time, and thanks to Dr. Bharat for connecting us to you. And I wish all the best for your cardiac center and also Sujivan Health and Wellness.
Thank you, and we'll keep on, we'll stay in touch, and we will together do much more things that will help in increasing the lifespan of patients.
Sure, because I have seen actually like a lot of patients with stroke and MI within our families, hardly in
Yes.
their 30s and 40s. I feel like we should do something and help them. And just look into the chat box. We are getting a lot of feedbacks there.
Yeah. Thank you, Karthik, for introducing FarmCon for me. And I'm like happy that he's reaching, Sujivan is reaching so many people. Ultimately, it's like teamwork, as I already mentioned in my webinar, that to make patient healthier and come out of the disease, it's like teamwork. Everyone has a role to play in making patients healthier and happier.
Yeah, and one final time, thank you for involving a lot of families in your practice and also in
Yeah,
Sujivan.
yeah.
I
Yes,
got a feedback that they are getting to learn a lot of things and the
yes,
freedom you give them
yes,
and the value you give them.
yes.
That is not true with all the doctors. Okay, so thanks and bye. So Alvin, you can
Okay,
end the session.
okay. And then thank you.